Welcome to Nanda Eye Hospital. Here we try to share our knowledge with the generation next, and I try to do the same through my YouTube channel, spreading the knowledge about cataract surgery and other ophthalmic surgeries. In this video, I am going to speak about how to be a complete cataract surgeon. So, is the knowledge of Phaco enough to deal with all cases of cataract? Just watch this particular cataract, very shallow anterior chamber. You can see the lens thickness is 5.64, and when you look at the cataract, it's a dense black cataract, and you can see the pupil is fibrotic pupil. It's a non-dilating pupil. You can see that PI or peripheral iridectomy has been already done, indicating that it's a case of chronic angle closure. And this patient has waited for a long time. Patient has lost other eye to the glaucoma and advanced cataract, and now patient wants to get this eye operated. Now plan here is to do manual SICS, MSICS. It has a lot of advantages in this case as compared to phacoemulsification. Most importantly, it is going to be least traumatic for the endothelium, particularly when the anterior chamber is very shallow and when you have such a dense cataract with very small pupil, and there is a possibility of zonular weakness as well. So here I want to show how to make a scleral tunnel. So after first groove, I have made that tunnel. You have to watch how the sclera looks, or how the blade looks through the sclera. It has to be just visible. If it is not visible, you are too deep, and if it is easily visible, you are too shallow. So this is the end point of creating the first pass through the sclera and into the cornea. And once you do that, you have to go sideways. First you go into the cornea using the crescent blade there, and when you are coming out, you have to cut the sclera. So that's the movement you must master. You first go into the cornea, and the sclera has to be cut when the blade is coming out. So the dictum is cut while coming out when you are making the scleral tunnel. You have to master this technique of making a manual scleral tunnel, because it is extremely important part of manual SICS procedure. If you make a very deep tunnel, you get a premature entry and iris prolapse. Now here I am making the side pockets, as they say. These side pockets are required for denser and larger nuclei, because when I make the entry into the antechamber, once I try to engage this large nucleus, these scleral pockets help, because the nucleus comes and gets engaged into these pockets. So first I have made just one entry, that is 2.8 mm entry through the scleral tunnel, and that is to introduce a B octaring. Now because it's a kind of a fibrotic pupil, I am going to use these two Uglen hooks to stretch the pupil further, and I am going to use B Octa, which is a 8 millimeter pupil expander by Dr. Suven Bhattacharjee. So this goes through that 2.8 entry that I have made, and I am using the B hex forceps. So always remember that there are three places of resistance when you are doing manual SICS. So here I am going to tackle the first point of resistance, which is pupil. So the two flanges go under the pupil, as you have seen. It's not difficult at all. So I'm using a B octa in this case for the first time, but it's very easy. You can see I'm holding those eyelets there and then pulling them towards the center, and then we have to put alternate flanges under the iris, so it hooks the iris. The last flange will be little tricky, because this is a quite small pupil and also kind of a fibrotic pupil, so it might provide some resistance, but because I have done stretch pupilloplasty already, it will be easier for me. So the last flange goes under the iris there, and it's nicely tucked in, and you can see now I have got large, quite almost 7.5 to 8 millimeter large pupil, which is extremely important because now I am going to tackle the next point of resistance, which is the capsular axis. So here I am targeting at least 5.5 to 6 mm capsular axis, and here in fact I am trying to get little bit even larger than 5.5, around 6.5 mm axis, because this is a very big nucleus, as you can see. Now the hydro dissection has to be very minimal. I am going to push just little bit of fluid, because in these dense cataracts, if I push a lot of fluid, there is a chance of hydro rupture. Nucleus rotation is achieved, and now I am going to make the final entry through the scleral tunnel. So this is the third point of resistance, which is scleral tunnel, and you can see I am using this 2.8 keratome, and I am trying to cut while going in. That is important because then you get the scleral entry parallel to the limbus. Okay, now I am going to use the two Sinskey method, where the first Sinskey slightly pushes the nucleus away, second Sinskey goes under the nucleus using it as a fulcrum. I am going to rotate this nucleus out from the bag. So here the resistance of CCC should not be there, that's why the need for large CCC. And once it is out through the CCC, I have tackled the second point of resistance, which is the pupil. The B octa ring helped a lot, that it kept the pupil dilated and avoided any resistance to the iris, to the nucleus to come out. And now I have already enlarged the scleral tunnel to a large size. So the third point of resistance I already tackled, and I am going to just engage this large nucleus into that scleral tunnel there first. Once it is engaged, you can see once I press the posterior lip, it comes out easily. So I could manage to take out this very big nucleus there, and it's always nice to see this nucleus which has come out in toto, trophy for the cataract surgeon. And once that is done, I'm going to take care of the cortex now. With these kind of black cataracts and then small pupil, fibrotic pupil, there is always a chance that zonules might be weak, and that's what I have seen now, that when I try to remove this cortex from the area on my right side, I found that there is some amount of dialysis there. So I'm going to take care of that using CTR. So this B octa ring really gives a big visualization almost till the zonules. So that's why I could pick up the zonular dialysis as well. If you don't have B octa ring, like earlier, I used to use iris hooks. With iris hooks, when you have pulled up the nucleus, it's better to remove the hooks around the scleral tunnel so that it can be delivered through the scleral tunnel easily. And then if you still want to see under the iris, you can put those hooks again. So here I am just managing that dialysis using the CTR, and you can see my left hand is trying to keep the CTR in the bag. So it's always a bimanual technique, so that you do avoid the CTR jumping out of the bag anytime. So once the CTR is in, you can see the bag has stabilized, and the cortex or the epinucleus which was there in that dialyzed area just came out on its own. Now I am going to put a 3-piece IOL. Here the technique that I am going to use for such cases is the IOL trap technique, where the 3-piece IOL is dialed into the sulcus. That's what I am doing now. The B octa again provides a good pupillary dilatation there, and one of the haptic was still in the AC, so that I dialed it back into the sulcus. You can of course push the IOL directly into the bag as well, but here for the long term stability I am going to do this, that I am going to do the optic capture into the CCC while the haptics remain in the sulcus. Thus the sulcus and the CTR in the bag both provide adequate support for the bag as well as the IOL. I have pushed some OVD, cohesive OVD, and then I am going to remove this B octa, which is not tough at all. You have to disengage the all the flanges from the iris, and then you can easily pull it out through the main incision there. That is the end of it. I am going to suture this tunnel because it's almost like 7 to 7.5 mm large tunnel. So if I take a suture, it will take care of the astigmatism also. And this is just 3 hours post-operative. You can see that the cornea is crystal clear. The patient is extremely happy with the gain of the vision there. Patient was literally in the darkness for last few months, and after removal of this black cataract, patient can see. Patient is of course extremely happy. For more such videos, do subscribe to this channel and give your comments. I'm looking forward to interact with you. Thank you.